I'll just introduce. The first block is by Dr. Vrushali Ponde. She is going to give a caudal epidural on a child. This is the live relay from the operation theatre. Before that, I will request the moderators, Dr. Bande, Dr. Sai, Dr. Charles Dang, and Jyoti Kaya to come on the dais, please. Vrushali, you can brief the case now.
This is a child. He is posted for circumcision, Sandeep.
Yeah.
5 years old and 20 kilograms. I am aspirating 0.25 ml of bupivacaine for him. I am kind of keeping the drugs ready. So Sandeep, are your delegates happy with the workshops today?
No, they are very happy. Dr. Bande, good morning, Vrushali. They are very happy.
Good evening.
Good evening. Okay.
Yes, I need a good morning.
Thank you. A extremely expert panel of clinicians and practitioners here to show us various aspects of various kinds of block, and at least the workshop which I attended was very good. I hope so.
Did you attend?
Number 4, Dr. TVS.
Okay.
And
beta team, and I went. Okay, that's very nice to hear. Okay, what is staring at the screen is supposed, it might look like a smiling face or about to smile face, but this is actually posterior superior iliac spine mark and a sacral cornus mark. Okay, I'm just cleaning it with beta team for you. I'm sorry to ask, may I know whom am I talking to?
this is Dr. Bande.
Dr. Ponde.
Bande. B-A-N-D. Bande. Pune.
Okay, Sandeep, this is Dr. Bande. This is our good old caudal, a block that fits every possible surgery on the from the toe till probably the higher abdomen or lower thorax. So this is one technique which is here to stay as long as pediatric regional anesthesia is here to stay. Now, since this is the first block, there are certain advantages of proclaiming yourself as a pediatric person. So they all give you first blocks so that kids are not starved much, and then you are done with.
Dr. Bande, can you hear us?
Yes, we can.
Okay. I am Dr.
Volume is
Saundratikar.
little less.
Good evening.
Good evening.
Okay, now what I am doing here is I am cleaning the transducer. Alright, I have just cleaned the transducer so that to kind of disinfect it, I can't call it sterile, but I have disinfected it. I am cleaning it up, and now I will just put a tegaderm on it
What have you
so
cleaned it
that
with?
it should be cleaned with sterilium.
Okay.
Because in their manual, sterilium is a very safe agent to be put on the footprint also. So you can go ahead and give the sterilium coating here and then wipe it out. You can go till the tail also and wipe it out, and now you can put a tegaderm on it in a manner that there are no bubbles along the footprint. So this is the most delicate and important part of the transducer, and I am going to now put a tegaderm over it. I want the entire audience to note how it is put so that there are no air bubbles or creases to mar our ultrasound image.
How about using chlorhexidine for cleaning the probe?
Bande, now it's your chance not to be heard well.
Sandeep is asking question.
What is the question?
Yeah. What did you say? Chlorhexidine.
Okay, now has everybody seen the way the tegaderm is applied? So the tegaderm is applied now with no creases here. Okay. Though please don't concentrate on my gloves, they are a bit oversized, a 6 number, but still I guess somebody should manufacture smaller gloves than this. So I'm removing the tegaderm off, and now we are free to work. Yeah, so as I was mentioning, sometimes there are advantages of self-proclaiming yourself, okay, I do a lot of pediatric regional. So people give you pediatric blocks and then you are the first person, you kind of work like an opening batsman to the team and then get going with your blocks.
It's a different honor.
Okay, anyway,
Can you use the sleeve for the cable, because sometimes people demonstrate with that.
Yes, you can use it. Is in fact it's quite nice to use it. You know, there are two ways of looking at it. If I was to put in a catheter, I probably would have done all that. I also would have worn a gown. I would have put in a sleeve or a camera cover, and I probably would have treated the whole thing in a different manner. Since it's a single shot block, I guess we can get going with this much of preparation. So
Okay,
so now we've positioned the patient, we have marked our anatomy, we have prepared our probe, and now we will just get going with the block. Can you give me a nerve stimulating needle? Okay. Now whichever needle you use, whether nerve stimulator or your simple 2He needle, there are certain principles that you follow in ultrasound guided blocks. Number one is the entire assembly, the needle as the needle hub, and if you're using this kind of a needle with a long here dead space in the tubing, you need to flush all this first with saline or local anesthetic, which I have done because any amount of air is kind of, you know, not acceptable. It can sabotage your image. Well, let us visit Caudal in all possible manners. We have been using Caudals for now, I don't know, ages. We all gave it with loss of resistance technique, didn't we? Like we just blindly gave it. In the sense, we palpated the posterior superior iliac spine, then we came to the sacral cornu, then we kind of felt both the cornus, and then we got going with our block. So this is how we gave our block, and this was how the old tradition gave the block, and we give it like this even today, don't we? So now let us see how we have kind of, you know, walked ahead and evolved to get Caudal in the most safe manner as we could. So let's see what we have imparted safety to it, in which ways. Now I am putting on the nerve stimulator, and let's stimulate it now with a current of 4. These are phylums here, they need a bigger current to stimulate. I don't think the machine is on, so please on it.
Is there any blood coming through the needle? That is a doubt Dr. Charles is having here.
No, the blood, there is no blood as of yet coming through the needle.
Some black shadow was there, that's why he doubted about.
Okay, okay. This shadow you're talking about?
Yes.
No, not yet. Increase the current.
Shows the panel of that stimulator if you can, what you are doing there. What current.
Yes, yes. Do you have a... So we are supposed to be seeing anal contractions here, the perianal contractions, and if we aren't seeing it, I am not going to bother myself much, to be very honest to you. Okay, because then probably I'll assume that there is something wrong in the whole current here. Now let me pick up my favorite probe. Now I can see the contractions because the muscle, see, as I told you, if you are getting a perianal contractions as you are seeing now, is the audience able to appreciate the perianal contractions here?
Very much.
Dr. Ponde?
Yes, very much.
Yeah, can they appreciate this?
Yes, we can appreciate. We can appreciate, I said. Can you hear me?
So these are the perianal contractions. The machine that I am used to gives the stimulating current a little faster. So now that we have seen it, now let us get going. This is our second generation. So we did it with nerve stimulation, converted into anal contractions, and we knew that we were in the right place. Now if we want to see through ultrasound, this is how we would see it. We can see it in two ways. One is transverse and another is longitudinal with the orientation marker towards the caudal end. So when it is longitudinal. Let us look into the transverse scan to begin with. This is how the probe is kept, and that is the way the needle is introduced. The needle is already introduced, so let's start reading the ultrasound scan. I want the ultrasound scan now being shown. I guess they have the audience must have already grasped what it is here as probe and needle. Let us focus more on the ultrasound scan and open it up now. Let the full image be ultrasound and let the probe be a picture in picture.
Yeah, we can see that now. Full
Yeah.
image, yeah.
Now let us read this image. Can somebody decrease the depth for me? Yes, fine. Indresh, that is fine. Now let us read the posterior, the whole scan. No, please don't decrease the gain. I want that much gain. That's good. Okay. Now what is posterior in the whole image? So this is the posterior aspect. No, sorry, Indresh, that's the posterior aspect above. This is posterior of the child's body. Okay, and that's the anterior of the child's body. Alright, so this is how we have oriented. Let us look at the skin subcutaneous tissue. Higher up, yes, and then look at some structure which shows itself extremely well and then shows nothing beyond itself. So that is one sacral cornu out there, and the adjective given to it, that is shows nothing beyond itself, is because it is a bone, and bone does not show anything beyond itself, but it shows itself quite well. So can you see one sacral cornu? So is this clear?
Yeah, this is clear.
Okay, so now one sacral cornu and the other sacral cornu. So can you see the two sacral cornus?
Yes, yes.
Yeah, no, you are showing them the shadow. Please show them the cornus well. Yes.
You can see the hypodense shadows, yes.
Yes, okay. So very bright two sacral cornus. Well, so our whole caudal is based on them. Fine. So we have seen the sacral cornus. Now something that joins both of them, there is a hyperechoic line in between both of them, and that's the sacrococcygeal ligament. Indresh, you are showing them the base of the sacrum. Yes, that is the sacrococcygeal ligament. Now, is everybody clear about the two cornus and the sacrococcygeal ligament?
Yes, we can see.
Okay. Now, if you come a bit posterior to the sacrococcygeal ligament right now, yes, now the arrow is on the base of the sacrum. Okay. So, these are the three things that matter to us the most. Fine. If you want to see them even more clearly, decrease the depth even more. Can you see them very clearly now? The two cornus. Yeah. And then the sacrococcygeal ligament. Above, please, Indresh. Yes, and the base of the sacrum. Fine. So this is the ultrasound transverse scan of the at the sacral cornu level. Okay. Now we will go longitudinal because that is what we are more interested into. If you want to appreciate the needle, this is the needle here. It is an out of plane approach, so you won't see the needle as such. No, the needle on the scan. So please go to the ultrasound scan once again. Yeah. So the needle is here. Okay. I'm just moving it gently for all of you to appreciate. Yes, okay. Now let's read the longitudinal scan. You see the needle has already appeared, and I am withdrawing a bit so that I can read the scan for you well. Can you show them the artifact of loss of image? Yeah, this is loss of image because the probe isn't getting contacted with the skin that well. Never mind, we will see the ultrasound scan. If everything, everybody in the auditorium has understood the image, the picture, let's go to the scan. We'll remove the picture now. So show the entire screen as the scan. Yes. Now let us read. This is the caudal end. Okay. The caudal end is towards the orientation marker. Yeah. And now what we need to know is the floor and the base of the sacrum. Indresh, will you please point out towards one spine? Yes, that is the spine. Okay?
Yes, yes.
Yeah. Now there is the base of the sacrum. Yes, that's the base of the sacrum. Just note that below the spine you saw nothing, but later on you saw the base of the sacrum. That's the base of the sacrum. Fine. So you saw the roof and you saw the base. Fine. Now the needle is amidst the phylum terminale. Sandeep, can I request you to show it with the arrow? Yeah. Now decrease the gain a bit so that they see the needle very well.
Imagine you can see.
Yeah. Now can you see the needle very well now that the gain is decreased? Yeah. So the needle is in between the phylum terminale and we will start injecting the drug now.
Level of depth of the needle.
Okay, how much needle is introduced inside? Just wait, don't inject. Hardly 2 centimeters.
Okay.
Yeah. Okay. Now you can see the drug coming out through this. Inject 2-3 cc's and wait. Can you see the drug flowing through the needle?
Yes, yes, we can.
Okay. Can you get the betadine a bit closer to me? Now what we do is, we utilize this caudal for some other purpose also. Can you please increase the depth? Now what I am trying to show you is the posterior dural sag that actually happens because of the drug that is being placed through caudal. Can you increase the depth? Yeah, fine.
It's increased by 2.7. Yeah.
Yeah. Now let us see if we can see the posterior dura. Yes, we can see the posterior dura now. Sandeep is going to show you that. The cursor gets stuck, is it?
You just describe then if you can.
Okay, I will describe the anatomy from the posterior aspect onwards. What he's just showed you was the posterior dura. That straight thin line, hyperechoic line is the posterior dura, and the bone above, that's the bone above. The bone, the white structure, yeah, that is the bone.
Okay.
Okay. Now if you increase the depth even more, you might see the anterior dura too. Fine. So you see the anterior as well as the posterior dura. Anterior dura I'm not very sure, it can be the anterior complex as such. Okay.
Isn't it too deep? What is the pulsatile structure there?
The pulsatile structure is the intrathecal space, in fact. That's the intrathecal space. Okay, and the bone that you just saw posterior to the posterior dura are probably the laminal levels now. Fine, and in between the two bones there is a window that you get and you start seeing your posterior dura. Alright, now let's see whether the injection that has happened in the caudal indeed reaches this level or no. I'm suddenly louder, can I be heard there?
Yes, yes, you are.
Okay, now start injecting once again. Now let us concentrate on this white line and let's see whether it falls. Keep injecting till it reaches there.
How much volume has been injected?
A volume is 0.5 ml per kilogram.
No, how much has been injected so far?
How much is 8 ml has already gone, and you can see that the posterior dura, no, I'm not too sure, yeah. Can you see the posterior dura kind of sagging down?
Yes, we can see that.
Yeah?
Yes, yes.
Yeah, but it hasn't definitely sagged down on the above level, okay? So our drug definitely has reached this level. Was it very clear to the audience that the posterior dural sag can be the sign of a correct caudal placement, and in other words telling us that we can also see whether we are congruent to the surgical incision? Any feed?
Yes, yes, yes. Please
Yes. Okay, fine. So this was the caudal with all possible ways of doing it. So we started with simple ways of traditional technique. There's some more. No, this is normal saline.